So very kind of you. It's very nice to see so many people taking interest and sit here in this hall. And I would like to recognize Dr. Vasavada Caliber, corneal experts being here. And it's very, very nice. Amar is taking interest and sitting in the front row. Amar, thank you for coming. I do have a financial interest that I receive research grant support from Alcon Laboratories, but nothing to do with this, and acknowledge my colleague Viraj's contribution on this topic. But I must say, I don't have any crystal ball that I can predict like some of the stalwarts here. But let's go through this, the present and the future, and particularly, which is more relevant, how it has affected me in various ways. And at this point, I was the 17th person in India to buy this machine, and not the early ones. And I have this for 1 year and 8 or 9 months. But it affected my mindset, and I had a dilemma. And I gave a talk which you heard David Chang giving why I didn't buy it for many years in many international and national meetings. But that was a dilemma, and I had to overcome this. Is it really better for me and for my patient, and is it safer for the patients? And that remained for a while, and that was the reason I took time to adapt to this technology. But I tell you that having adapted it, and I echo what the experts have already said, that you need to have your own right perspective for yourself as a clinician, as a scientist, and as a curiosity and an urge to contribute to the science that will solve that dilemma. And also you need to convey that perspective to your patient in the right way, and therefore chair time has never been so important as it is today, and that applies to many of these things. But as we saw Dr. Ramamurthy and Chitra showing how it is done and how it affected, there is no question, as the DR said, that reproducibility of the size you want and you desire, which is the optimum for the patient, you can never achieve. Even if these experts sitting here won't be able to do it every time. So we understand how valuable it is in terms of PCO and many other effective lens position refractive outcomes, but it's truly accurate and precise, and that's really the essence. Even if for this reason I would consider adapting this if the economics in your practice and your team and in your background is favorable. But at this point of time, I want to refer to the article that recently published comparing manual capsulotomy versus 3 machines, Lens6, Optomedica, Abbott, and the Victor. I didn't do the study, I have no interest, but manual was outstanding in terms of homogeneity and the tags which David Chang showed, but the nearest or almost nearest was the Lens6 induced rexes compared to other things. So there is no doubt that on the electron microscopy, manual will stand out better. But what does it mean to us as a clinician and a surgeon? For a surgeon and a clinician, I can vow on the oaths that it is as strong as manual with femtosecond and induced once you go through the learning curve as you would go with any other. So you don't need to worry about that strength and the reports, what you find in the benches and laboratories. But phagofragmentation, maybe with a direct chop or no space and horizontal chop, you won't have a great advantage in a routine cataract, but in a dense cataracts and cataracts which has a hostile environment, as Chitra said, is definitely helps you mentally comforting, reducing the energy. As you can just see, only a little bit of a separation needed for that. And there are studies which show that it actually spends much less energy than this. But this is the area which I'm not very comfortable. Although this film shows how I did almost a very near limbal incisions, I'm not able to do it every time, and that's the major limitation today. So I don't perform this incisions as a routine all cases, but I do about 4 out of 10 patients I do when I assess cornea very well, but still it's not as limbal as I would have liked to do that. But that's something which you need to keep in mind, and obviously this is not a kind of case you would do that. Now, the real advantage is not the routine cataract. Well, for the experts, maybe you can do as good as you do 9.5 out of 10 times, but it is in the challenging situation, as Chitra put it so nicely, that really there is no debate in my mind as a clinician that it really has a role. My PCR rate with posterior cataract has come down from 8% to about 4%. And in these 4% cases, the tear was very limited, so that I could convert that into a rhexis situation. So I think the spatial situations, and one of them is the posterior cataract, I can tell you it's really a superior way to perform. White cataract, I think if you have a right strategy and if you've done, and many of you are more experienced than me, I don't see this many more now, but this is something has an edge, because the rhexis really is so predictable, and you can see it's freely floating. This is the true freely floating total cataract thing. I normally use Helon 5 and Trypan Blue, but this is something which is outstanding. I don't produce every time, but I do produce complete rhexis every time, not free floating like this. But this was very dramatic, so I thought I would use it to prove the point. So this is what it is, the same cataract. And I could do this many times, but not every time. And the real value is in the safety. And that's where the Fuchs endothelial dystrophy, the shallow chamber, the other things which compromise the cornea is something really is very valuable. But what I enjoyed, unfortunately, I'm not able to do it every time because of the money involved in this pediatric cataract surgery. But the point is, and I'm showing you to illustrate and to tell you that it's possible to do with this soft fit under GA, and this is the rhexis I produce and can produce. Anybody can produce if you have the machine like this. And I've done many pediatric cataract surgeries, and I've been able to do it quite well, I think, but nothing like this. And if you have a toric IOLs and some other things in children to match with this eye, you can understand. But not only that, but you can perform PCCC also. That does mean taking the patient out again on the machine, another PI, and therefore it doesn't work. It's not practical, I must tell you. And so I don't use femtosecond in a pediatric cataract surgery as a routine at all. But I did few for my own understanding, and it's nice to know that it's possible in a very selected way in a patients if they can afford. So what are the concerns? Subconjunctival hemorrhages, the difficult cortex, but as we heard, it's not a big deal. IOP rise is not a problem with any of these platforms we have. It does take a long time, so that's one thing. But how is it about the patient? And Maipal showed very cleverly and smartly how you can change the perception and use to the benefit of the patients more than yourself. And this is where the laser technology, the laser precision and the safety comes, and you don't need to worry too much about it. At the moment, my practice conversion is about 35 to 40%, as Maipal had in his own data. And it's amazing how that is translated to the satisfaction of the patients, which is obviously very beneficial as a business practice also. But the real issue is really the money. I mean, if that is available at one-third the price of these, what they quote and sell it, yeah, many would have it, because the fact is that it is no worse. The data today shows it is as good as manual. It doesn't show it is superior to manual today in the routine cataract, but the spatial situation, and the papers are coming, one of them would be ours, where we're comparing manual versus femto in a posterior polar. So spatial situation is something which really has an evidence being created now, and it's a matter of time, I believe, I hope, that it will produce a evidence also, which many of us as a scientist should ask for it, because that's fundamental. We just cannot say whatever is not evidence-based. But in summary, nobody needs a crystal ball for that. It's a continuing evolution of the technology, like many others. And long-term outcome have to be demonstrated, and we all are aware of it, and some of us are working probably on it. But overall, I would say we are moving as a futuristic view toward the more automated procedure, as some of our other medical surgical faculties have done in Rothschild and other surgery. So I think it is definitely on the horizon. I can see that very well. So thank you so very much for your patient hearing.